This meeting is being recorded.
Good evening, everyone. On behalf of TaskMed, I would like to welcome you all to Medcast Insights into Healthcare, a learning initiative by TaskMed. Today, it's a great pleasure to have with us Dr. Ashish Bhadkal, who is a consultant cardiovascular thoracic surgeon at Care Super Speciality Hospital, Nagpur, Maharashtra. Welcome you, sir.
Thank
Sir,
you.
we look forward to hear from you on today's topic of discussion, Mexelitine, an unexplored anti-arrhythmic drug. Over to you, Dr. Bhadkal.
Yeah. Thank you very much for giving me this opportunity. Today I'm talking about one of the unexplored anti-arrhythmic drug, rarely used by a surgeon and even cardiologist, that is Mexility, but results are excellent. I came across where one of my patient is operated is of mitral valve replacement. The piece of ventricular tachycardia was IC1 bolus and the loading, both the loading dose and the maintenance dose. And of course, then some of my friend he suggest with this drug, and we started Mexiliting with 150 milligram twice a day doses, and she respond on the very next day, and it's a very wonderful drug. Now she is fine. Uh, so that's how that was my encounter with this drug. And there I have mentioned another case where the case of dilated cardiomyopathy. She's 56-year-old woman presented with palpitation and restlessness for last 2 days. ECG shows white QRS tachycardias. You can see here, and there is a left bundle branch block and AV dissociation is there. Of course, the choice of drug was a mitoran that too in the bolus, and the results are great as usual. The sinus rhythm is restored. So, in this patient, the coronaries were normal and the cardiac MRI was suggestive of biventricular inflammatory cardiomyopathies with extensive fibrosis. Of course, ejection fraction was impaired. And the cause was non-known, but mostly viral, started on amiodarone and beta blocker. And patient, but after that, the patient again developed white QRS tachycardias treated with IV lidocaine, reverted, repeated AVT episodes are there. Patient was cardioversion was done, and oral amiodarone proton was started. But because of this, there is a prolonged QT interval, so amiodarone has to be stopped. So what are the choice there? The choice were ventricular overdrive pacing and thoracic epidural anesthesia. Those non this thoracic epidural anesthesia those not commonly practices in our routine practice, but in this case both the attempts were futile, and of course the patient was started on Mexilitine. In spite before that the patient was treated with for a sympathectomy. I haven't seen in my life the patient needs to go for any patients who are advise sympathectomy for these issues. But later on, that this patient was treated with Mexilitine, and after over a period of 3 days, the VT became infrequent, and after 48 hours, dual chamber ICD was inserted, and more patient was discharged in stable condition. So this is the common practice for cardiac surgeon or cardiologist who came across ventricular tachycardias. Coming to VTs, the types of VT that is monomorphic, polymorphic, torsus de pointes, in which there is gradual change in amplitude and twist in the QRS morphology, and bidirectional VTs, that is common feature in developing tortuosity. Coming to monomorphic VT, non-sustained VTs, sustained VTs, and incertain VTs. Non-sustained means those VTs which last for less than 30 seconds. These are non-sustained. More than 30 seconds is sustained. Incessant means continuous episodes of such VTs. And coming to this VT storm, that is defined as two or more hemodynamically stable VTs within 24 hours, VT recurring soon after termination of another VT episodes, or sustained or non-sustained VT resulting in total number of ventricular ectopy beats greater than the sinus beats in last 24 hours. Those patients with ICD insert in those patients with ICD, the definition is three or more appropriate therapies for ventricular tachyarrhythmias, including anti-tachycardia pacing or shocks within 24 hours. Hmm? But this definition is not comprehensive, as the VT that is lower than programmed detection rate of ICD, they are missed, and VT that fail to terminate with appropriate ICD therapy and remains undetected by the patient, they are also missed. Coming to the clinical syndromes of electrical storm, electrical storms develop in patient with a structural heart disease or in patient with when there is a scarring of myocardial markers. There is a triggering event in these locations which leads to the premature ventricular contraction, and that leads to the vulnerable anatomical substrates. Determining the cause of electrical storm is essential because that is must for the treatment to target underlying mechanisms. So these are the etiology. You can see the 75% are attributed by the coronary heart disease, then by cardiomyopathies and valvular heart disease. So when we come to evaluation of ventricular tachycardia, we generally the first and commonest investigation is the 12-lead ECG. That suggests that confirms our diagnosis, and to rule out whether there is any structural disease or not, we have to go for echocardiogram, and that suggests whether patient is having any valvular heart disease or even coronary heart disease, that is whether there is any regional motion abnormality, whether there is a scarring of myocardium that leads to the ventricular aneurysms. If if you see there is scarring, extensive scarring, the ventriculum and to the viable myocardium, we can go for MRI. Of course, conventional or CT disease. When ventricular tachycardia, coming to its this is the diagram just now I told, that is when there is a source of idiopathic VT which are originate from the primary arrhythmic syndromes, that is common as is provided. When there is another structural heart disease, just now we have seen that picture, that is 70 cardiomyopathy. Again, there is idiopathic dilated cardiomyopathy, SEM or cardiac sarcoidosis, and Chagas disease. Chagas disease is rare, very rare in our setup, that is parasitic disease it is. Coming to the management of VT. So commonest management is of course medical management, where using the anti-arrhythmic drugs. If they respond, bias therapy, that is ICD insertion, and ectopics, localized catheter, and mostly by catheter, and rarely bias therapy nowadays. So coming to the specialty storm, it's extensive treatment, find out the cause, whether it is ischemia, whether it is electrolyte imbalance or fluid overload, and treat accordingly. So early pharmacological is coming to the as anti-arrhythmic drug, of course, first line of management of VD. Its effect is it is rapid in onset. Effects are there, decreasing frequency of ICD shocks, contraindications and side effects of each antiarrhythmic drugs. These are the disadvantages of therapy. So another reason and diabetes is ICDs that prevents this. Then if there is VT storm, the recurrent idiopathic VTs are ablations that reduce the ventricular sympathetic innervations. Coming to our main topic that you must have seen from the party, class 1, class 2, class 3, and class sodium channel blockers. Class 2 is beta blockers, channel blockers. The main focus is on the class which is available in IV form. That is the drug of choice. Always first drug of choice in ventricular tachycardia, yeah, this then coming to the Mexelitine, that is the very novel drug for class 2 in dose of 150 to 300
The
milligram, 8
PPT
hours
is not
with
visible
the
now.
hello.
The PPT, sir, is not visible.
Okay.
Please share it.
Now it is visible.
No, sir. You have to share the screen once again, I think.
Okay.
Yes, sir. Now it's visible.
Yeah, okay. coming to Mexility, the doses are from 150 to 300 milligram QID, the TDS or QID if required, and indicated in ventricular tachycardia, ventricular fibrillations, PVCs, and it has definitely role in patients with the long QT syndromes. It acts on the sodium channel, sodium channel blockers. The as same as Hilocard, it has no effect on any intervals. In rarely, QPCs can slightly be shortened. The half-life is almost 10 to 14 hours, metabolized by liver and excreted by urine. The 10% is excreted unchanged. The common adverse effects are heart failure and heavy bundle block. So Mexilitine, it is US FDA approved it for the treatment of ventricular arrhythmias, and Drug Control General of India indicated the Mexilitine in existing or anticipated ventricular arrhythmias and ectopic beats that found after myocardial infarction or in patient with ischemic heart disease. It is indicated for the arrhythmias induced by drugs and idiopathic arrhythmias. So these are the guidelines, more or less same indications are there. Coming to its mechanism of action, how it acts, it inhibits the inward sodium current. This phase 0, and a side of action is Purkinje fibers. This effective refractive rate is that result in increasing ERP and action potential duration ratios. That is mechanism of action. So main important thing is it acts on the Purkinje fibers, not on any node, AC node or AV node. So hence there is no change in the duration. So the property is definitely similar to lidocaine because it's the same class. The patient with normal conduction system, there is a minimal effect on cardiac impulse generation and propagation. There is no development as I already told, second degree and third degree block, no development of second and third degree block. And in patient with pre-existing condition, there is a pre-existing condition defect. In those patients, there can be depression of sinus rate, prolongation of sinus node recovery time, and decrease in conduction velocity and increase ERP and interventricular conduction system. This is the same. You can see in this chart this lidocaine and Mexilitine. This is the only drug who don't have any effect on SA node, AV node, or any intervals. So wonderful these drugs are. There, no decrease in the cardiac output, blood pressures and pulse rates remain essentially unchanged. This is not a case in case of this is not in case of amiodarone, where there is decrease in the significant decrease in pulse rate occur, and even in case of beta blockers. There is what happened there is just mild depression of myocardial functions. But most important part is blood pressure and heart rate, they remain unchanged. Coming to its pharmacokinetics, absorb is excellent. The distribution is 50 to 60% bound to plasma protein. Metabolism is mostly through liver, and the first pass metabolism is low. That is unlike Xylocard. Elimination is mainly by kidneys, and half-life is almost 20 to 14 hours. Coming to its dosage, initiate with 200 milligram every 8 hours when rapid control of arrhythmia is not essential. When there is rapid control is required, you have to give loading dose of 400 milligram, and after 8 hours give 200 milligram, and continue as per required doses. When there is rapid control is not essential, we can start with 200 milligrams of 200 milligram dosage every 8 hours, and we can increase the dosage to 300 and 400 milligram with a gap of 2 to 3 days. The absolute contraindication is, of course, cardiogenic shock and pre-existing second and third degree block. Mexelitine is adverse effects. It is generally well tolerated. Mild GI disturbances is there, lightheadedness, tremors. Coming to management of sustained monomorphic VTs, that is the VTs which last for more than 30 seconds. In those patients, this is the flow chart. How we have to manage the sustained monomorphic VTs after the 12-day ECG, and after a history, due to the echo, rule out any structural heart disease. If there is a structural heart disease, try for cardioversion for immediate effect. If required, start propanamide and amiodarone, and in spite of that, if they are not responding, start Mexelitine. The class 2B indications are there. If VT terminates, then it's fine. Otherwise, again cardiovert, and if required, then go for catheter ablation last. If there is no structural heart disease, then management these two pharmacological drugs, that is verapamil and beta blockers, they work excellent in these conditions. So coming to summary, the Mexelitine is indicated in sustained ventricular arrhythmias. It is a drug with a moderate potency. The agent with appropriate safety, that is safe in LV dysfunction, safe in QT prolongation, and this is the most important actually. It is safe in QT prolongation, and this is the advantage over amiodarone. And the effect is reversible in non-lethal adverse effect. There is a class 2 indications recommendation for really used as add-on drug. Into summary, the management of, and most of the time it's hybrid. That is a combination of one or more therapies required. Treatment of VTs is a challenge and needs to be individualized. That depends on whether patient is having structural heart disease or not. In structural heart disease, high risk pulmonary VTs, ICD is the first line therapy and is the gold line therapy. Of course, catheter ablations considered early for recurrent cases, recurrent sympathetic idiopathic VTs. Medical line therapy is acceptable for minimally symptomatic idiopathic VTs, low risk subgroups of polymorphic VTs. Thank you very much for your patience hearing.
Very well elaborated, sir. So I'll request the participants, if they're having any query, they can put their questions in the Q&A box.
I think most of the listener must be busy with their practice. Okay. Thank you very much for giving me this opportunity, classmate. Thank you very much.
Sir, so thank you, Dr. Bhadkal, for joining, and it was really an insightful discussion for us and as well as for our listeners. And I would also like to thank all the doctors for being with us for their active participation during this. Thank you and have a great day.
Bye.